Chapter 5: Right Atrial and Central Venous Pressure Monitoring. Central venous pressure is the pressure in the large thoracic vein near the right atrium. CVP directly measures the pressure in the superior vena cava, and considering that cava openly communicates with the right atrium, it right atrial pressure. CVP normally correlates with the end diastolic pressure of the right ventricle, which is the filling pressure. As the right ventricle fills, the tricuspid valve is open, allowing open communication between the atrium and the ventricle. Near the end of diastole, the pressure equalizes, resulting in a reflection of the right ventricular pressure. Overall, CVP reflects the relationship among the intravascular volume, venous tone, and right ventricular heart function. Now I have CVP also correlates with left ventricular end diastolic pressure in individuals without cardiovascular disease and is a means of assessing left ventricular function. New CVP catheters have the ability to measure continuous central venous oxygen saturation. This type of monitoring is used for the early identification of patients with global tissue oxygen deficiency, hypoxia, and early implementation of therapy. CVP monitoring is a way to measure right heart function directly and measure left heart function indirectly. Normal CVP pressure ranges from 0 to 8 millimeters of mercury. CVP is measured by placing a radio-opaque catheter, usually via the jugular or subclavian vein. The catheter tip lies in the superior vena cava near the right atrium. Serial or continuous provide a method for directly assessing right heart function status and indirectly assessing left heart function. Catheters for central venous insertion are made from a variety of materials. Complications vary with the material from which the catheter is made. For example, catheters made of polyvinyl chloride are likely to cause the most reaction in the body, possibly resulting in phlebitis or catheter-related thrombosis. Celastic catheters are more chemically inert and more flexible. Their flexibility makes them more difficult to insert. The intended use of the catheter determines its type. CVP measurements should be taken with the patient's supine. However, if the patient's condition prohibits placement in the supine position, the head of the bed may be elevated up to 30 degrees. If the patient is unable to breathe when orthopnic and cannot tolerate degrees or less, measure CVP in the patient's position of comfort until the orthopnea is resolved. The patient's clinical condition prohibits placing him or her flat. Document the position of the patient when the reading is obtained. Serial readings may be obtained with the patient in the same position to establish a trend. These will be lower if the patient is in an upright position as a result of gravity-related changes in the intrathoracic blood volume. Variations in patient position will need to be taken into consideration when interpreting the readings. Central venous catheters may be single-lumen or multi-lumen. Multi-lumen catheters are commonly used in critical care units because when using a single-lumen catheter, fluid or drug infusion is interrupted for CVP readings. Catheters have 3 infusion ports that terminate 2.2 centimeters apart at the distal end of the catheter. If a percutaneous sheath introducer with side arm infusion port is used, a 4th lumen is available. Multiple lumen catheters provide a mechanism for simultaneous fluid and drug administration, as well as continuous CVP monitoring. The patient's physician will select the type of catheter required by the patient's condition. Central venous catheters are most often inserted via the jugular and subclavian vein. The femoral vein may be used, especially if the patient has coagulopathy, because the femoral site may be directly compressed if the artery is lacerated. 3 veins, the femoral site is the least commonly used because of the increased risk of catheter-related sepsis and the knee leg relatively straight. The following discussion relates to the jugular and subclavian sites because these veins are most commonly used. One should be available to assist the physician, and another person should be available to circulate or monitor the patient. Before the catheter insertion procedure, you should prepare the patient and the family, explain the purpose of the central catheter and the procedure in simple, non-technical terms, obtain a signed consent, facility, assemble the equipment, place the patient supine in a Trent-Ellenberg position of 15 to 30 degrees unless this placement is contraindicated by the patient's condition. The Trent-Ellenberg position promotes distension of the veins of the chest, neck, and head, making venous cannulation easier. Ellenberg position engulfed with blood. So you pretty much holding the patient head down so all the blood rushes to their head. Also, you instruct the cooperative patients on how to perform a Valsalva maneuver before the procedure. The Valsalva maneuver is forced exhalation against a closed glottis, similar to bearing down to have a bowel movement. The Valsalva maneuver increases intrathoracic pressure. Having the patient perform the Valsalva maneuver at appropriate times during the procedure and placing the patient in the Trent-Ellenberg position reduces the risk of air embolus. Consider and provide, if necessary, pre-procedure sedation for restless patients. So, we directly measure from what I've read. It directly measures the right atrial pressures. Read indirectly the left heart function or pressures. So CVP normally correlates with the end diastolic pressure of the right ventricle, which is also the filling pressure. In persons with normal hearts and lungs, CVP correlates to left ventricular end diastolic. 3 important tips to remember. Normal CVP ranges from 0 to 8 millimeters of mercury. A few other good questions that I'm not able to show are how is the catheter determined? How is the type of catheter used for central venous cannulation determined? It is determined by the intended use or patient's condition. What is the major advantage of a multi-lumen catheter instead of a single lumen catheter? Multi-lumen catheter allows for the simultaneous administration of fluids and continuous CVP monitor is not interrupted. Is the insertion of a central venous catheter a sterile, clean, or emergency procedure? It is a procedure. What is the best position to have the patient supine position? The zero level of a water manometer or the transducer should be placed where on the body? The transducer or zero level of the water line should be placed at the plebostatic axis. What is measuring CVP with a pressure transducer? In current clinical practice, CVP is typically measured with the use of a pressure transducer. A pressure waveform is available for analysis. Readout is available. All hemodynamic monitoring equipment consists of a transducer, an amplifier, a display module, and a fluid-filled catheter. The transducer senses a physiologic event and transforms it into electrical signals. The amplifier amplifies the filter and filters out interference and transmit the signal to the display module. The catheter and flush system maintain the patency of the catheter. When measuring CVP with a pressure transducer, a continuous right atrial pressure tracing will be observed on the monitor. 3 upward deflections correspond to phases of the cardiac cycle. The A wave is produced with atrial contraction. It's normally the first and highest peak. Enlarged A waves may indicate right ventricular failure of any cause. In atrial fibrillation or flutter, A waves may be absent. E wave is produced when the tricuspid valve closes. C wave is below the A wave. The bulging of the tricuspid valve into the right atrium as the right ventricle contracts produces the V wave. So a good question to remember. What produces the V wave? The bulging of the tricuspid valve into the right atrium as the right ventricle contracts. Large V waves may indicate tritation. The downward deflections, the X and Y waves, depict atrial diastole and emptying, respectively. So it's just going down from the A wave is atrial diastole and going down from the V wave, emptying, because it's open and it's sending all the blood out of the atrium. Measured with a pressure transducer, continuous printout. The right atrial pressure is measured at the end of expiration. The A wave corresponds to right atrial contraction. The C wave is produced by tricuspid valve closure. The V wave is produced by ventricular contraction. What is measuring central venous pressure with a water manometer instead of a transducer? Although CVP is most often measured with the use of a pressure transducer, it may with a water manometer. The major advantage to water manometer is its simplicity and quick setup time. Water manometer is attached in line with the IV fluid administration set and comes with a pre-attached stopcock. When the stopcock is off to the manometer, the IV fluid may flow through VP. The nurse may attach the water manometer to the IV pole, level it with the phlebostatic axis using a carpenter's level or a meter stick, and measure readings with the manometer on the pole. The nurse may also remove the manometer from the pole and hold it at the phlebostatic axis for each reading. Continuous reading is not possible with a water manometer, so that is the major disadvantage. Serial readings must be obtained on a regular basis, and the trend is documented to provide information for making treatment decisions. Water manometers function by filling the chamber with IV fluid, opening the chamber to the patient, and allowing the fluid lies with the pressure in the right atrium. Once the manometer is open to the patient, the level will fall rapidly. The column of water should stop falling and fluctuate when the pressure equalizes with the right atrium pressure, which will give you the CVP reading. The water column may fluctuate with respirations. Readings difficult, so readings are noted in centimeters of water, and they're normally just an average. To obtain CVP readings with a water manometer setup, you should wash your hands, place the zero level of the water manometer at the phlebostatic axis, turn the water manometer stop flush bag, fill the water manometer about 2/3 full. Do not underfill the manometer. Underfilling may cause an inaccurate reading. Open the water manometer stopcock to the patient. Watch the fluid column closely. Do not allow all the fluid to flow out. When the column begins to fluctuate, CVP reading, then you have to turn the stopcock open between the flush solution and the patient, and then you record the readings. Water manometers are commonly used to measure CVP. False transducers are true. Continuous CVP reading is possible with a water manometer. False. To prevent air embolus, it is important that the nurse does not allow all the fluid to flow out of the water manometer. That is true. True or false? The CVP reading should be obtained when the fluid column fluctuates. That is true. So remember, do not allow fluid to overflow from the top of the manometer. This overflow will result in contamination. Also, do not allow all the fluid to run out of the manometer, cause an air embolus. CVP is the pressure in the large thoracic vessels of the chest and reflects the pressures in the right side of the heart. P is a reflection of the right ventricular and diastolic pressure or preload. Alterations in preload affect cardiac output. Abnormal CVP, altered right heart function, and volume status. It is important to remember that an isolated CVP reading is not as valuable as a series of readings, so trending is always better. The trend of the CVP will communicate more about the patient's condition. CVP measurements are most often used to assess and manage intravascular volume status. Alterations in CVP most directly reflect a right-sided heart function. Increased CVP may indicate any of the following: intravascular volume overload, right-sided valve disease, right ventricular failure secondary to left ventricular failure or left heart failure, such as myocardial infarction, mitral stenosis, or cardiomyopathy. Right ventricular failure secondary to increased pulmonary vascular resistance. Right ventricular failure as a result of right ventricular infarction or A significantly increased CVP often indicates volume overload. Overload may result from over-aggressive IV fluid administration. Takers can cause patients to have increased Other reasons that may cause an elevated CVP relate to conditions that overload the right ventricle. Example, pulmonary hypertension or right ventricular failure. These conditions causing the right ventricle to be unable to eject properly is what elevates CVP. Decreased CVP may indicate hypovolemia, alteration in venous tone, dehydration, hypovolemia may be the result of dehydration or blood loss. States such as septic shock, extreme vasodilation occurs, resulting in relative hypovolemia. In this state, the poor venous tone causes poor venous return to the heart, hypovolemic state. Other signs of hypovolemia may include elevated heart rate, decreased blood pressure, and decreased urine output. A normal CVP does not necessarily mean the optimal volume status. Compensatory mechanisms can keep cardiac output at normal levels, at least temporarily. A patient taking vasoactive drugs may have a normal or elevated CVP hypovolemic state. Mechanical ventilation may falsely elevate CVP readings. Positive pressure ventilator breaths increase atrial pressure, venous return, and therefore decrease cardiac output. Use of positive and expiratory pressure further increases intrathoracic pressure, often causing unpredictable CVP readings. However, it is not clinically sound to remove patients from mechanical ventilation just to obtain a CVP reading, because that's just a reading. The mechanical vent is their breathing, especially the patients who need to have positive and expiratory pressure. If hypovolemia is suspected, the clinical response to fluid challenges are more meaningful CVP reading. A rapid infusion of 300 to 500 ml fluid in a normal volemic healthy adult will increase CVP by 2 to 4 millimeters of mercury. The reading will return to baseline in 10 to 15 minutes. A CVP that does not return to baseline in 10 minutes indicates increased intravascular volume, a non-compliant right ventricle, or both. So what is indicated if CVP does not return to baseline in 10 minutes? Normal healthy person. A CVP that does not return to baseline in 10 minutes indicates increased intravascular volume, a non-compliant right ventricle. Hypovolemia is possible if the CVP fails to increase or return to baseline in 5 minutes. Okay, so common complications of CVP monitoring and appropriate responses. So if the complication of hemorrhaging is present, overt hemorrhage may occur from the insertion site. Acute bleeding may occur into a body cavity or cause a deep tissue hematoma. That's pretty much bleeding underneath the skin. So, the appropriate response to overt hemorrhage is to check for visible signs of bleeding, such as bruising or swelling, and apply pressure as appropriate. And for acute bleeding, monitor the patient for signs of acute bleeding, such as hypovolemia, restlessness, pallor, and tachycardia. Pneumothorax. If pneumothorax occurs with a CVP, it could be because of the procedure itself. Just the insertion of a CVP caused a pneumothorax, which is pretty much a hole in the lung. You're putting a foreign object into the body. It could puncture the lungs, and that is a pneumothorax. But that rarely happens. Overall incidence of a pneumothorax is 1 to 2%. Increased evidence may occur when the subclavian vein is cannulated. Evidence for pneumothorax may occur when patient is on a mechanical ventilator with high PEEP. Appropriate responses for pneumothorax: monitor the patient for dyspnea, cough, and sharp chest pains. A pneumatic X-ray. The patient has to get a chest tube placed. Other complication that is common with CVP monitoring is vascular erosions. They occur days after insertion. It's caused by vessel wall irritation, by stiff catheter, or infusion of hypertonic solutions. May cause accumulation of IV solution or blood in the pleural space or mediastinum. Appropriate response for vascular erosions is to watch for new pleural effusions or widening of mediastinum on chest X-ray. Monitor the patient for sudden onset of dyspnea, tachycardia, and tachypnea. Other complication is dysrhythmia, irritation of the right atrium or ventricle as a result of catheter migration. So it moved from where it's supposed to be. Particular ectopy may occur when patient is turned, may stop when patient is returned to a If the catheter migrated from where the doctor placed it, then they have to reposition it. Sometimes it goes too far, or it's almost coming out. There's four other complications include infection, fluid overload or hypothermia, thromboembolic complications, and air embolus. Infection may occur as a result of contamination during insertion, inward catheter migration, other infected area, contaminating tubing, or IV fluids. It may be local or systemic. Appropriate response is moderate or hypothermia, chills, localized redness, swelling, heat, purulent drainage, or above the insertion site, and unexplained escalation of white blood cell count. Fluid overload or hypothermia caused by unregulated IV fluid bolus. Relatively small amounts of fluid that are accidentally infused may be hazardous to the critically ill patients. Appropriate response: you monitor the patient for tachypnea, dyspnea, hypertension, and pulmonary diuresis for fluid overload may be needed. So that's pretty much medicine for the fluid. And to prevent hypothermia, administer warm IV fluids if large amounts of fluid are to be infused. Thromboembolisms from a CVP. Catheter lumen may become occluded by blood clot. A clot may surround one segment or all of the catheter. Migration of a clot may result in pulmonary embolus, which is deadly. Appropriate response: you do not force flush a central venous catheter to prevent dislodging a clot. Support of a multi-lumen catheter is not in use. Flushes may help prevent thrombus formation. Periodically flush each port to prevent clot. Treatment requirements: anticoagulant therapy to break up the blood clot or prevent it. Air embolus: the vascular system during catheter insertion, removal, or any time during which the tubing is being disconnected. Collapse and death may result. Each alert patients, the Valsalva maneuver is the appropriate response. They're pretty much coughing while closing the glottis. Monitor the patient for sudden cyanosis, tachycardia, and hypotension. Immediate therapy is to place patient on left side so the bubble will go up and out of the right side of the heart. And you give them 100% oxygen. So air bubble can kill you. Fun stuff. Decisions about treatment of the patient should be based on the trend of CVP readings. Low CVP readings may be an indication of volemia. Clinical response to a blank is more meaningful than an isolated fluid. Clinical response to a fluid challenge is more meaningful than an isolated CVP reading. Isolation may alter CVP readings. Infection may be caused by contamination during insertion, inwardation, and contaminated tubing. A pneumothorax usually occurs A. 1 to 7 days after insertion, B. Immediately after insertion when the subclavian site is used, C. After long-term central venous therapy, after insertion when the jugular site is used. Apparently, it's when the subclavian site is used immediately after you can get pneumothorax. What is central venous catheter removal? Central venous catheters may be removed for a number of reasons. The reason for catheter removal is that the patient's condition has improved and that it is no longer needed. Catheters may also be removed if they become damaged or the patient develops an infection. Unfortunately, the infection may be systemic or localized at the catheter insertion site. Removed because of damage or infection and the patient's condition warrant the need for the catheter, the physician may choose to place a new catheter in a different location. When removing a central venous catheter, is critical. Bolus is a complication of central venous catheter removal. It is important while the patient is performing a Valsalva maneuver to thoracic pressure. During removal, resistance should be minimal. If significant resistance is met during removal, stop the procedure and assess with an X-ray. The catheter may be knotted or kinked. One complication of a central venous catheter removal is fat embolus, infection, air embolus, or hemorrhage. It's air embolus. This is met when removing a central catheter. Should you apply a more steady pressure? Should you stop and should you advance the catheter? Or stop and get a chest X-ray? All right, and that's the end of it. That's the end of chapter 5.